Hi, I'm Dr. George Sledge from Stanford University and co-chief scientific advisor for Susan G. Komen. It's my very great pleasure to introduce to you the winner of this year's Brinker Award for Scientific Distinction in Clinical Research, Dr. Judy Garber. Dr. Garber leads the Division of Cancer Genetics and Prevention at the Dana-Farber Cancer Institute. During her distinguished career, she has performed trailblazing work in clinical cancer genetics for breast cancer, advancing our understanding of the role of BRCA1 and BRCA2 mutations in breast cancer treatment and prevention. She's also been the teacher of a generation of cancer geneticists with an impact far beyond Harvard. She's played an important leadership role at a national level as well, serving as president of the American Association for Cancer Research and as a member of the National Academy of Medicine, among many other honors. So please join me in welcoming this year's Brinker Award winner, Dr. Judy Garber. Dr. Garber.
Hello, I am thrilled to accept the Brinker Award for Scientific Distinction in Clinical Research from the Susan G. Komen for the Cure. I have been a supporter of the Komen Foundation and a recipient of their generosity for many years, and I am tremendously honored to receive this award today. My lecture will be entitled Breast Cancer Genetics Comes of Age. This is my disclosure information. And let's begin. So the BRCA1 gene was mapped by Mary Claire King, a former recipient of the scientific component of this award, in 1990. And soon after, in 1994, the gene was cloned, and shortly thereafter followed by BRCA2. And also in 1990, TP53 was linked to the Li-Fraumeni syndrome, which includes very early onset breast cancer, and which I will also discuss a little bit in this talk. So here's a classic family with breast ovarian cancer, multiple generations, early onset disease, and often we are concerned with the unaffected member of the family, thinking about genetic testing to avoid a cancer diagnosis. But today we're really going to focus on her sister, the breast cancer patient, since all of us here are likely to be involved in the care of breast cancer patients at the San Antonio Breast Cancer Symposium. These are recent data from 2021 in the New England Journal from two separate groups, providing us with data from large cohorts looking now at unbiased collection, so not collected anymore from the study of cancer families, as most of our data comes, although one can argue that that is pertinent for women we see, but nonetheless showing the prevalence of these genes, their clustering for ER positive or ER negative disease a little bit differently, and in the graph above looking at risk by gene over age. And these are important age-specific risk curves for helping patients make decisions about managing risk. The criteria for genetic testing in the US and around the world has really evolved. So in the early days, we used to think about what was the probability that a mutation would be identified as the main driver. And now we also think so much about how we would use the information. So in this slide, we're looking for age under 45, so all of our young breast cancer patients can be tested for a mutation or a pathogenic variant. We don't use the term mutation any longer. For those under 50, some family history might help. For those under 60, triple negative breast cancer. And then we've really added to these criteria, not just any longer the family history segments that we have always looked at, but the collections of ovarian, pancreatic, metastatic or advanced prostate cancer, other family history, remembering that the technology changed in 2012 and went to next generation sequencing, which made it possible to identify pathogenic variants that would have been missed by the Sanger sequencing. So patients who were tested before 2012, and this may vary by country, could consider repeat testing with more advanced technologies today. Now we are testing tumors, and it is possible to identify a germline mutation as part of that analysis, and those data should not be ignored. And with the findings of Olympiad and Embraca, we went to looking for germline variants in individuals who had met criteria for treatment in their first or second line of therapy with a PARP inhibitor. And then just this past summer with the publication of Olympia, which we'll discuss, and the advantage for the adjuvant treatment of a subset of high-risk patients with BRCA1 or 2 mutations, the idea that genetic testing should be used at diagnosis to help determine treatment is now made official. So there are a lot of opportunities for using genetic information as part of medical oncology management. Certainly surgical oncology has always been part of this. Radiation, not so much for BRCA1 and 2, but certainly for TP53 and sometimes for ATM. The consideration of second primary cancers, reproductive decisions to allow one to select against passing on the disease or at least to avoid the possibility of a partner with a mutation that would lead a child to have Fanconi anemia. Cascade testing of family members, very important and underutilized no matter what we seem to do. And then other questions that I will actually not handle so much today. So here are data from Memorial Sloan Kettering, not our data, but just showing that the prevalence of mutations or pathogenic variants in predisposition genes among people with advanced cancer is significant, 15 to 17%, and not always predicted by the tumor. Certainly technologically you can find this also in cell-free DNA. And in the Memorial data, the important finding that 60% of germline mutations in BRCA1 or 2 would have been missed if the strategy were only to suppress the germline findings to enable identification of acquired mutations for targeted therapies. And while that was the main goal of treatment, germline information, as we've discussed, does give a guidance or an eligibility for some types of treatment. And also, there is importance on its own for the management of second cancer risk. Breast cancer survivors may want their ovaries out sooner than later, or management of the second breast, for example. And then there is the family. So one does not want to miss the opportunity to use all of the data generated from tumor germline testing. And in fact, there's much more move toward tumor and germline combined testing by several different testing laboratories. This is an exercise that was done by our group with Sridhar Ganesan's group at Rutgers, looking at the germline data that we had acquired and our tumor data to ask how good are the algorithms that help you to use tumor DNA or tumor data only to predict the presence of a germline mutation. And you can see that even with this excellent group, we were 86% accurate, that was all, but that LOH in the tumor was present with 72% when there was a pathogenic variant and only 58% when there was a variant of uncertain significance. So this is a beginning. I don't think any of us would consider this ideal data to skip germline analysis, and given that it's not so difficult, one might wonder why not really do both, but we'll see where this works out to be. Now, our group was interested in platinum for a long time, and that's because of the presence of David Livingston and Alan DeAndrea at Dana-Farber, who were both really key to the finding that the function of BRCA1 and 2 and other genes that seemed important in triple-negative breast cancers had to do with homologous recombination repair. And the idea that platinum could induce errors that would not be repaired well in tumor cells missing both copies of BRCA1 or 2 led us to this small trial of neoadjuvant platinum now quite a number of years ago. And what we showed in this study was that we could achieve pathologic complete responses with platinum as a single agent, only 22%, but all of our BRCA carriers, all 2 of them, had pathologic complete responses and others as well. So it encouraged us to go forward with platinum. Well, others also have worked in platinum. Here's Andy Tutt's data from the TNT trial showing a benefit of platinum in first-line metastatic disease in individuals with either germline or acquired BRCA mutations and no one else. And then the contradictory Gephardt-Sixto data in the neoadjuvant setting showing that the only beneficiaries were individuals who did not have a germline mutation. And here with Nadine Tung and others, and I will do this, although it's not complete, so it could be a mistake. In the INFORM trial presented last year at San Antonio, we showed the results of a study randomizing among BRCA1 and 2 germline mutation carriers with either cisplatin or standard AC, and showing really no benefit, or at least no superiority, of cisplatin as a single agent, with a disappointing pathologic complete response rate and no group in which this was superior. So cisplatin certainly does have a role, or platinums have a role in the treatment of breast cancer, but not as single agents in the neoadjuvant group. And that is still true. We see platinums used in many other studies in BRCA carriers and triple negative patients. The PARP inhibitors fortunately came along around the same time. So here we were thinking about DNA repair, and here's DNA repair now being interfered with in the same way in tumors with homologous recombination deficiency, with the loss of both copies of their BRCA1 or BRCA2 gene, at least, with PARP inhibition primarily working through PARP trapping, but also still interfering with repair of double-strand breaks. And in the old days, with a study led by Andrew Tutt in breast and a companion trial in ovary, we showed that olaparib was active as a single agent, and this was a heavily pretreated group of metastatic breast cancer patients where 400 milligrams twice daily was clearly better than 100 milligrams. That's what the Kaplan-Meier curves show. Here's just an example of disappearance of pulmonary nodules in a short exposure. So this was data that there was something to this PARP inhibition, although I think that there was impatience on the part of some in drug development that, the ovary group, who had many fewer alternatives, progressed much faster than breast. Nonetheless, here's Olympiad and Embraca showing that in the metastatic setting, at least in early lines of therapy against a single agent other than platinum, PARP inhibitors offered an advantage in progression-free survival, if not in overall survival, and this led to their approval and to the indication for genetic testing in individuals at the time of metastatic disease diagnosis. And here, since I was one of the co-PIs, we get to talk about Olympia. Again, this is the adjuvant trial that was presented just 6 months ago at ASCO, looking at 1,836 BRCA1 and BRCA2 mutation carriers who received all of their adjuvant or neoadjuvant therapy, including surgery and radiation, before randomization to olaparib, 300 milligrams twice daily, or placebo. The group included triple-negative patients, ER-positive patients if they had more than four or more positive nodes. All of these had to be high-risk patients in the treatment. The study, as you know, was stopped early because of the by the Data Safety Monitoring Committee, because of the improvement in invasive disease-free and distant disease-free survival already apparent. And overall survival has not been seen, and I don't know whether it's not yet or it will not be, we can hope. And the subgroup analysis showing no specific group benefiting or failing to benefit in this trial. Importantly, the drug was quite well tolerated as an oral agent for a year. And then there were symptoms that were different, but these were not statistically significantly different, and not thought to be clinically different by the patient-reported outcome data presented at the in June, and more are presented at this meeting. And then importantly, for very focused question about safety with the adverse events of special interest, MDS, AML, pneumonitis, and second primary tumors, perhaps because this is short follow-up, we have not yet or have not seen a statistically significant difference. So a well-tolerated drug with an advantage for events, this has led to activity. Now, the obvious question then would be if we have approval for Olympia early for the use of olaparib in the adjuvant setting, is olaparib active with any of the other DNA repair genes in the pathways that were identified to show that these that these genes are part of families of genes, not individual. And here's just a list of the genes that would make patients eligible for participation in TBCRC 048, the olaparib expanded trial. These are all DNA repair genes, although they are not all in the same place in the pathway, and they don't all confer the same magnitude of risk. But this is just a randomization of no, I'm sorry, this is a non-randomized study of olaparib after in metastatic disease. I'll get there. In the germline cohort, we had remarkable responses in the PALB2 patients with all of them having some response, and failure to see response in this very small study cohort in CHEK2 or ATM. And again, responses in somatic BRCA1 and 2 mutations in the absence of a germline lesion. So that led us to an expansion of this trial for those groups. But we are here doing this basically one gene at a time. This is the prostate cancer approach, which was to look at all DNA repair genes at once and to get an approval for a PARP inhibitor in the presence of those mutations. I think we'll have to look at what's the most efficient or perhaps what's the best route to drug development, evaluating these. And now, of course, we're faced with the issues of resistance. Any targeted therapy will, and there are multiple mechanisms for resistance to PARP inhibitors. There are studies of ATR inhibitors, which seem quite promising, and many other approaches involving combination therapies. Now, with immunotherapy in particular, because of the data at the same time showing improvements for non-mutation carriers with other modalities, and now we will have to think about how to use these together to benefit our BRCA1 and 2 pathogenic variant carriers. So let's shift gears a little bit and talk about prevention. For ovarian cancer, really prevention has been a surgical approach in the absence really of an early detection strategy that's effective or any kind of chemo prevention option. And we have in the WISP trial from MD Anderson and the Hutch, with participation from Dana-Farber in this Stand Up to Cancer supported study, but only 270 patients really looking at quality of life. These are based on the data that ovarian cancer precursors may form in the fallopian tube fimbria and fall onto the surface of the ovary, and that removing the fallopian tubes alone might help reduce risk. So here is the NRG trial now asking, not in a randomized study, but can we at least show that there is reason to suspect that this is an effective strategy, salpingectomy alone with delayed oophorectomy versus the combined therapy. At least we showed in WISP that women were willing to do this, and now in SOROC we'll have more data, including more PRO and health-related quality of life data to at least inform patients about the risks and benefits of this strategy. The question about whether the uterus should be included in surgical approaches comes from the study that we did with, led by Noah Kauf and Ken Offit at Memorial, asking, do we see uterine cancers? These are based on very small numbers, although they were statistically significant only in BRCA1. And interestingly, particularly after tamoxifen, although we all know that that's a small number of patients with BRCA1 whose tumors would require tamoxifen for treatment. So still challenging data, but they have led to more and more consideration of hysterectomy as part of preventive surgery. On the breast side, we have these fascinating data from Jeff Lindeman in Australia showing rank ligand, a progesterone-regulated molecule, still being essential in the development of BRCA1-associated breast cancers, the triple-negative tumors. And in mice, with an inhibitor of the mouse equivalent of rank ligand, we can show shutdown of proliferation in mouse mammary tissue and delay in the development of mammary tumors. And this led to a phase 3 chemoprevention trial randomizing between denosumab, the human rank ligand inhibitor, against placebo in women with a BRCA1 mutation. The study's being led through the ABCSG by Christian Singer in Austria and Jeff Lindeman in Australia and me in the US. And this is Sue Friedman, whose advocacy group FORCE will be essential to the success of the trial in the US. The study has opened in Austria, Australia, Spain, and Israel, and will shortly open in Germany, the UK, and the US. Here are just the distribution of our sites, with a primary objective of reduction in invasive and pre-invasive breast cancer, and secondary objectives that will look at other clinical endpoints, and then a DoD grant that will support the use of a lot of translational science with these very rare specimens and clinical data. So we're very excited about this trial and hope people will find it of interest. Years ago, Jos Jonkers, very early on, saw the potential of the PARP inhibitors for prevention, and in his BRCA1 knockout mice gave olaparib and showed that they could delay the development of mammary tumors. This is fascinating data, and now that we have Olympia saying perhaps this is a possibly safe approach to consider, a group of us put together a grant. I have no idea what will happen to this, but asking, could we start to address the important questions of dose, schedule, and biomarkers to begin to develop a PARP inhibitor in a prevention mode. Of course, no one would give a PARP inhibitor daily as we do for chemotherapy, worrying about long-term risk. We have other questions to ask about safety and resistance, but perhaps we will get to look at this question. After all, the Susan G. Komen had funded a promise grant to do this 10 years ago, but the FDA thought maybe we were crazy and it didn't happen. Let's just spend a few of these last minutes talking about another condition, Lee-Fraumeni syndrome, in which I have spent much of my career. This is Fred Lee and Joe Fraumeni, inspiring mentors who studied hereditary breast cancer and hereditary cancer syndromes before there was molecular genetics. This is an example of their syndrome, which they identified in 1969, which includes very early onset breast cancer, multiple primary tumors, sarcomas, adrenocortical carcinomas, brain tumors, and others. There are multiple criteria for calling Lee-Fraumeni syndrome, including TP53 testing, since no other genes have yet been linked to the syndrome, although there are families that look like Lee-Fraumeni and do not have a TP53 mutation. There are a number of challenges that have led us to think about redefining Lee-Fraumeni syndrome. One is the common problem of missense mutations in the TP53 gene, and this is from work from Bill Hahn, my colleague at Dana-Farber, and Andrew Giacomelli, who took each of the missense mutations and substituted all of the possible for alleles and then went and estimated their chance of being pathogenic. So here's a pretty common TP53 variant that shows to be quite solidly in the pathogenic range, and this is the founder mutation in Brazil, which scores over here less convincingly. So this is an issue of how we define pathogenicity for some of these variants. The other issue is the recognition that not all families may look as classic as the family I showed you initially. First, in this work from Humarana in our group, showing that if you test people for a single gene looking just for P53, either because they look like Lee-Fraumeni or maybe someone else in the family has a mutation, you see that earlier onset disease, looks the same for breast cancer only, and in those whose TP53 variants were found in the course of multi-gene panel testing, as we usually do these days, they are later onset, they look less dramatically like the syndrome. Here is a variant identified and studied by Kara Maxwell at Penn. This is a founder mutation in the Ashkenazi Jewish population, and this has the unusual feature of sometimes looking like classic Lee-Fraumeni syndrome, and then in other parts of the family history may look much less penetrant, and this also increases the challenge of Lee-Fraumeni syndrome. Aberrant clonal expansion, or CHIP, recognition that there can be acquired TP53 variants in the hematologic compartment only, predisposing to hematologic malignancy or to cardiovascular abnormalities. This will come as a TP53 result on a blood test, but the allelic fraction will not be 50% or even close. And so we looked at 84 consecutive probands in our clinic with TP53 variants and found that only half of them roughly were germline, that some were constitutional mosaics, meaning that, for example, their breast tissue and breast tumor had a TP53 mutation, but their blood did not. So they really are mosaics. We did find ACE or CHIP in 15%, and 2 of these were people with CLL, where the TP53 variant was confined to their lymphoma cells. And then we had a few that we could not figure out. So if you see TP53 in the clinic, it is not always Lee-Fraumeni, and it's worth trying to sort that out. And fortunately, in a paper we did, led by, again, Nadine Tung, there's a very nice diagram to help take you down the path of how to work out what these people may have and what the implications are for their management and their relatives. And then we have a study trying to redefine the epidemiology of the syndrome. This is together with my colleagues Steve Gruber, Chris Amos, and we hope that you'll refer your patients to it so that we can try to give better answers about how they can manage their cancer risks and quantify them for the future. As you can see, there are many more colleagues than I could acknowledge on those slides. This work could never be done alone, and I almost entitled this talk Cancer Genetics Through Collaboration. There are many people to thank, but foremost among them my husband Miles Brown, who is himself a recipient of a Brinker Award. I can't imagine it would have been any fun, and it certainly wouldn't have been as interesting to have this career without them. This is my group on the right, who have been wonderful, productive, amazing, stimulating colleagues in so many ways. And on the left, Miles and I with our own genetics experiment, our children, and now the newest addition, our wonderful grandson, Evan. These are my clinical colleagues, without whom this would not have worked either. They have been patient and supportive and allowed me to work in this space. And they make themselves remarkable collaborations and contributions every day. And I thank you for your attention, and again, the Susan G. Komen for the honor of this award.